Otherwise, thank you for that introduction. Yes, I do have fond memories of us working and having meetings together in the Northern Territory. Ever since I continued to work in Aboriginal health as a GP, as also supervising GP registrars in Aboriginal health. I also have an interest in systems change, so was involved a lot on boards. Currently, as Isaac said, I'm on the board of the Australasian Society of Lifestyle Medicine, where I'm the president for the last year and was elected again for this coming year. But I'm also chairing the therapeutic guidelines company as well. This is a topic that sprang to mind recently, but which I have been practicing for the last 23 years. And I just want to share the progress in the science of deprescribing, but also to talk from a personal perspective about the art of doing deprescribing as well in the context of lifestyle medicine. Firstly, I just want to just inform you about our society. We are a fairly young society, but we were probably one of the first one to start in 2006. I won't go through all the dates, but we really introduced the concept in 2009. And then we create the textbook around that time as well, and it's still going. It's been translated into 4 languages on the practice of lifestyle medicine. We joined the global movement in 2015, and we've just joined the World Lifestyle Medicine Organization this year. And we're just continuing to expand our operations. And we're really keen to engage with lifestyle medicine society around the world. And so when Isaac gave me this opportunity, I grabbed at it because it's always good to make friends. And if we can help each other out, that will be great. Because there is a increasing scourge of chronic disease and mental health issues, and no country really is spared around the world. Although we started a few years ago, I believe that our membership is still small. There's only 932. We're hoping to increase that. It's really, and therefore it's really a movement, and we're trying to increase our footprint. Lately, we had a lifestyle medicine conference. It's probably our 7th one. It's an annual conference. It's part of the mix of education that we provide online through webinars, workshops, fellowship, and board certification. I just couldn't help myself but include a picture of Isaac, Dr. Samanja, which I think you know. Who's come into this forum before. So it's a great forum to meet friends and acquaintances and strengthen our bond. We're very lucky in Australia to have masters in lifestyle medicine. 3 tertiary institutions offer these for our members and the wider community, and we're very engaged with university and colleges to promote the lifestyle message. So this is the textbook that I was mentioning, and in this textbook it mentioned 4 key principles in terms of clinical practice in lifestyle medicine. First, you need the science, the knowledge. You do need the art. There's a lot of procedures and communication skills and psychological techniques that is required in lifestyle medicine. There's tools, and there's also procedures. And some of these procedures are still developing. One of those procedures is shared medical appointments. I think you had a chat about shared medical appointments with John Stevens. But one of those procedures is also deprescribing, and that's what we're going to talk about today. So without further ado, I'm going to launch into deprescribing and tell you a little bit about that. So I'm just going to go through deprescribing, what it is, what are some of the barriers, what are the process of deprescribing, and then I'm going to introduce a few tools for you, which is based on science, and it's widely used, and you can easily access this online afterwards at your leisure and just review it, because there's quite dense information there. And then I'm going to put it in the context of lifestyle medicine and give you my experience of deprescribing in Australia. So firstly, what is deprescribing? So deprescribing is a positive. So it's very, very important to communicate this to the patient. That is a positive approach to patient-centered care. It's conducted under medical supervision. So, you know, it's the doctor that starts the medication, it's the doctor who can stop the medication. That reassess the role of all medication with a view of stopping some of those, okay? Especially those that have no clear benefit. They are medicines that may cause harm, medicine that are being used for an indication that is no longer an issue, and that's an important one for lifestyle medicine, and a medicine that's no longer fit for the current goals of care. So that's the general definition of deprescribing. And actually, I should mention to you that deprescribing was first coined in the English language. I'm not sure in other languages, but certainly in the English literature, it was only in 2003 that we started talking about deprescribing as a clinical process. And it was started in Australia too, by the way. So the goals of deprescribing is to improve care, is to minimize polypharmacy, and this is becoming an issue in older population, obviously, but also it is to minimize harm. Now, the benefits of deprescribing, there are many benefits for the patient, but the potential benefits of deprescribing include these. It can potentially reduce drug interaction and adverse effects. Now, this is obviously important when there's more than 3 drugs and we're talking about polypharmacy. It does improve or can improve the function and quality of life. So these are medications that might impair cognition and behavior, or it may cause homeostatic conditions, or the orthostatic hypotension issues that, and therefore can reduce the rate of falls in old people. It has potential to simplify drug regimes, although you don't need to do prescribing for this to occur. You can modify the dosing, you might modify the dose and simplify a drug regime that way, but deprescribing can also simplify the drug regime. It certainly can reduce costs for patients, although that's not the main driver. It can reduce costs for patients, and it can certainly reduce medication error, especially when the patient is actually managing their own medication and there's more than 3 or 5 medications to contend with. And so those are the benefits, but there's also harms that we have to consider. Signs and symptoms of the original condition may reappear when a drug is withdrawn. That's probably one of the main fears of doctors and patients when that occurs, especially if patients have been on the medication for some time and they're so used to taking these medications. So withdrawal syndromes may include, and it depends on the drug, withdrawal effects, so confusion, seizures after abrupt withdrawal. Benzodiazepine is an example. There could be a rebound effect, so rebound tachycardia after withdrawal of beta blockers, rebound acid secretion after abrupt withdrawal of a proton pump inhibitor. However, we should say that these withdrawal syndromes are rare when deprescribing is undertaken slowly and appropriately under medical supervision. And that's shown out in the literature. You can reduce the dose or frequency rather than complete cessation. So that's another option instead of deprescribing. And it's important that the patient and the doctor do not interpret these withdrawal syndromes as a recurrence of symptoms of the original disease. Okay, this is withdrawal; it's not the recurrence of the original disease. So it's very important to eliminate that. So withdrawal symptoms, although potentially is a harm, it's very rare. So when should you consider deprescribing? Well, when there's obviously no clear benefit any longer, okay? When the drug actually is causing harm or may cause harm, and this occurs in the changes in the patient. So the patient may have losing reserve as they're getting older. They'll be more frail, more disabled, and have multiple comorbidities that may affect the pharmacodynamics and pharmacokinetics of medication. When there's multiple care providers and the and of course the prescribing cascade, so there's just so many drugs being introduced to the patient. Now, the prescribing cascade is where you start a medication and there's side effects from the medication, but you don't realize it's actually from the medication side effect, that then you introduce another drug to combat those side effects, and so on. So that's what we call a prescribing cascade, okay? When you realize there's a prescribing cascade, that's a good place to start thinking about whether we should deprescribe. So pharmacodynamics, as I said, with age, receptor sensitivity do decline or change. And pharmacokinetics, the absorption rate, the distribution, so protein in the blood, elimination rate, reduction in renal function and liver reserve, all have a role to play in determining whether deprescribing is possible, because it can cause harm. When else do you consider deprescribing? When it's been used for an indication that is no longer an issue. So this is probably the most important one for lifestyle medicine, because if people institute lifestyle medicine approaches and there's lifestyle improvement leading to improvement in risk and leading improvement in clinical parameters, that means that that condition or state is no longer an issue, and therefore deprescribing should be considered. It should be also considered when the drug is no longer fit, does no longer fit with the current goals of care. For example, preventative drugs are often used, like, for example, statin. When cholesterol and lipids profile has improved, or when patients are so old and frail that statins are no longer appropriate or are doing anything for the patient, you can deprescribe those. Okay, here are some of the barriers to deprescribing. So deprescribing is not for everyone, and the barriers exist in the doctor as well as the patient and their families. So from a doctor's point of view, there's a lot of fears and a lot of restraints, a lot of frustrations that occur that will become barriers to deprescribing. There may be an underappreciation of polypharmacy harm. Doctors may feel like they need to follow clinical guidelines, even when the guidelines really doesn't apply to older people. Maybe it's over 70, maybe it's over 80, but they feel like they need to follow these guidelines because of whether it's lawsuits or the managers or supervisor are telling them what they need to do. There's a fear of unfavorable consequences of deprescribing. And so I mentioned withdrawal effects and so on. And those fears, from research is not well founded, but there's definitely fears there. There's fears that the patient or their family will complain because the drug was recommended by experts. So if you're talking about me as a GP, and it's started by a specialist, there's fears that the patient or family will complain and give negative feedback about that approach. Doctors feel that there's not enough evidence. So evidence-based medicine, randomized control trials indicating when to stop medication. So there's not enough research and data. That is improving. And I'll show you some of the drugs that has evidence for you to stop prescribing. And maybe doctors are unskilled at reducing polypharmacy. And one of the big things I think, all those things considered, is that doctors may not have enough time, because deprescribing does take time that you spend with the patient and also monitoring the patient as you go along. So that's the doctor's fear. So it's well founded, but as we do more research, hopefully some of those fears will dissipate. But there's also barriers in the patient themselves. So on the purple side, the patient and the family, the attitude is, I've got an illness, you've got to give me something. Okay, so it's very strong attitude that there is a drug for every condition. So what will you give me instead? Who are you to question or change what experts have prescribed? Okay, so these are complaints we mentioned before. Patients themselves have an underappreciation of polypharmacy. Okay, so when patients have side effects, they don't know whether it's drug-related or whether it's a disease process. Some feel that is an economic incentive for the system to save money. So when you suggest deprescribing, they may be suspicious that you're just trying to save money for the system. I'm not sure how medication is subsidized in Kenya, but certainly it's subsidized in Australia, and some patients will feel that we're not doing it for them, but we're doing it for the economy. There is certainly anxiety and fear of the consequence of stopping medication. So we're talking about withdrawal syndromes there. There are some myths and pressures that is shared by doctors and patients. So this is the middle green square here. So there is a belief doctors heal diseases by drugs alone, okay, which is not true if we are thinking about lifestyle medicine approaches. There's also myths that there's medicines for each disease. Okay? Every disease has a drug, which is, we know for that is not true. Taking medicines to treat or prevent disease is a must, So, if there's a drug to treat or prevent a disease, that's what you should do. And also in lifestyle medicine, we'll say, better drugs, and it's called lifestyle medicine, that's than pharmaceuticals. Biased doctors and researchers in for-profit companies will push medication. So there's a lot of pressure to prescribe in the doctor. Certainly, they do this directly and indirectly through marketing to pressure doctors, to pressure patients as well. So in Australia, drug companies can't advertise directly to patients, but I know that some other countries can And so there's pressure on the patient to ask for medication. And so there's pressure also on the doctor to prescribe and use medication. So these are quite an extensive list of barriers to deprescribing. And what I'm trying to get at is there's a cultural issue, not just a medical and clinical issue in deprescribing. As a society of lifestyle medicine, our job is not just promoting lifestyle medicine, but also changing the culture around how we see chronic illness, mental health, and the treatment of those things. So very important to ponder deeply about those issues. Okay, so this is the process that you go through for deprescribing. And I've got lots of references. I'm happy to hand it over to Isaac, who will distribute it for you. Okay. And there'll be articles and guidelines that you can read at your leisure. But this is a summary. So the first part of the process is you need to think about the patient. Does the patient understand their options in care, including deprescribing? Does the patient have certain values and preferences and goals in life? Do they have values regarding quality of life as opposed to quantity of life? Okay, so you need to assess the patient. What's their attitude to lifestyle medicine, to lifestyle behavioral change? What are their internal resources and capacity to do this? And do they have support from their family or carers or advocate? Because that becomes really important to help the patient to move in the process of deprescribing. Once you assess that the patient is suitable for deprescribing, you need to compile a comprehensive medication list or history. So the number of medication, are there high-risk medication? Has there been past or current toxicity? Is the patient's parameters important in terms of toxicity? So, for example, age, their life expectancy, their frailty, their physical and cognitive function, their dexterity, and whether they have lots of comorbidities or not, and whether they're actually adhering to medication in the past or currently. That becomes an important topic for discussion as well. So once you compile a medication history, you then have to identify medicines that are appropriate to cease. Okay, so not all medication is appropriate to cease. So these medication, as I mentioned previously, there's no benefit, it causes harm. Medication that treat symptoms like proton pump inhibitors should be, on the list of targets, okay, especially when there's no benefit for them. They tend to be used short-term, but for some reason they become lifelong. Preventative medicine need to be considered, because once you address lifestyle issues, the preventive medicine is no longer of benefit. Or if the patient is very old, they're no longer of benefit as they don't reduce any more risk for the patient. And also adherence problems with some of the medication. If you have a lot of medication during the day and patients find it hard to remember to take the medication, it may be you're reducing or deprescribing that medication. You then have a list, and then you have to prioritize which medicine should be ceased first. So here you ask the patient what they want, and decide and agree on the specific medication to change. And you should do this one at a time, and you should do it slowly over weeks or months, and it needs to be a stepwise approach. And once the patient agree which to deprescribe first and second and so on, you do need to have a written withdrawal plan. This requires a bit of education for the patient to improve their health literacy. You need to initiate the deprescribing close to an adverse. Most of the time, there's an adverse event and you have to reconsider the drug list. So it's important to have this discussion and then deprescribe close to the adverse event. The reason is that the patient is more motivated because they can still remember why they went to hospital, for example. Make sure there's time review scheduled into that plan. So close follow-up and support is required to solve problems and to maintain motivation for the process of deprescribing. Monitoring and documenting outcomes is very important. So you need to document withdrawal symptoms, communicate and inform other people. So there's a family, pharmacists, carers, nursing staff, what is happening in terms of the deprescribing process. So that's basically the process that's being promoted as a process for deprescribing. And it is involved, and it does require a certain attitude from the patient and the doctor for deprescribing to be successful. All right, I'm going to introduce a few tools, and they're growing, but these are a few I think are really good for you to know about. The first is called MedStopper, and MedStopper is designed not for lifestyle medicine, but designed for aged care and end-of-life care. It asks you firstly whether the patient is frail or elderly, and then it asks you to list all the medication. And then it tells you as a summary which medication may be considered or prioritized for deprescribing. It's a very nice tool. So if a patient has 3 or more drugs in the older age group, this is a very good tool to give you an idea what you should consider in terms of deprescribing. So that's in the beta format, and hopefully the more people use it, the more feedback they have, and then there will be a really good tool for you. But I urge you to use that just out of curiosity, if nothing else at the beginning, but also just remember it's there for you if you're seriously considering deprescribing, especially in the older population. And this is another tool to assess frailty. It's called the Edmonton Frail Scale. I'm happy to send an article on this for you. It's very simple, and you score it. And if they're frail, you certainly need to start thinking about deprescribing for these patients. So consider their cognition, their health status, social supports, nutrition, their mood, whether they're continent, and whether they're functionally okay as well. Okay, so that's a measure of frailty. You may know that already if you work in aged care. Now, I mentioned there's a lot of research in certain medication that is suitable for deprescribing. There's a whole list of these medication. And I picked this one out because this is for diabetes, and we all know that lifestyle measures can put diabetes into remission. And so therefore, deprescribing anti-hyperglycemics is definitely top of our list. The other reason why it's top of our list is diabetes is so common in our countries that we should know about deprescribing anti-hyperglycemics. And so there's a whole process, algorithm to consider as you are thinking about and then deprescribing anti-hyperglycemics, which is good. The beauty of this is it's translated into an app as well. And this app is called IAM Medical Guidelines. Okay, this is from the Canadians, and it's very good. I hope it's available in Kenya. It's certainly available in Australia, this app, and you can download onto your phone or iPad, something like that, and use it as you will. Okay, so those are the main tools. I'm just going to go through an example well, it's not an example, it's just a group of patients that I've been deprescribing, or start the process of deprescribing. And this is a group of patients, Aboriginal patients who have diabetes. So it could be any patients with diabetes, it doesn't have to be Aboriginal. But I just want to start with Aboriginal because 23 years ago, when I was working as a GP registrar out in the bush, I came across this article. And this article basically took 10 Aboriginal women who are semi-traditional from an urban context into their country, into the bush, for 7 weeks. All of them have diabetes, some of them quite significant diabetes, all of them were overweight. So the intervention is very simple. They just plonk them out there for 7 weeks. There were no activities, there's no encouragement or anything like that, but they were just living on country. And what they noticed was that there was lower energy intake. So, and most of the energy intake were from animals. And Australian animals have very low fat, okay? And so their fat intake was very low because they were hunting and catching native animals. There was a slight increase in physical activity, and this is from gathering food, preparation of food and hunting as well. But there's only so most of the change was in the content and the frequency of how they eat. What wasn't measured, and I put this in because lifestyle medicine, there's 6 pillars. It's not just exercise and diet. There's also about stress. You can imagine it would be less stressful. You can imagine there'll be more sleep. You can imagine that, they did document it, there's no alcohol use. You can imagine there's social connection. And more than that, for Aboriginal people, connection to country is very important. So all those factors were not measured, but I can tell you it does have an impact on stress, sleep, and mental well-being for Aboriginal people. And I'm sure those things has an impact on the outcome. And what are the outcomes? The outcome was that on average, people lost about 8 kilograms in 2 months, or about 2 months. The glucose tolerance improved from 11.6 on average to 6.6. They improved postprandial glucose tolerance tests as well, and the fasting insulin fell as well, just after only 2 months. And they found that the lipids profile also significantly improved. So when I saw this article, I thought to myself, hang on, if these things improve with lifestyle measures, that means I can take these medications off. There's no need for these medications. So I had a thought of deprescribing already, and I started doing some deprescribing. This was in the year 2000, and it's only in 2003, as I told you, people start using the word deprescribing. So I had a sort of a head start in thinking about these things. And this is the community that I worked in. And I created a program whereby we improve diet, exercise, community, social connection through team sports and the like. And we visit the women's center, and we taught them about food and nutrition. We taught them how to cook and how to use Western food. This is one of the issues, that Aboriginal people are given a Western store, but they haven't been taught how to use those food. And one of the things they ask us is, we have no idea what this is. We just ignore it. They say, well, this is good food. We need to teach you how to use it, right? So we did that, and there was marked improvement in exercise and diet, and marked improvement in diabetes. And one by one, I was able to encourage people to increase their physical activity and improve their nutritious intake, so that I can deprescribe. And to this day, in an urban context, we still do that. So when I When I look at the process of deprescribing, one of the first thing I do with patient when we consider the patient understanding and their options is to teach them about lifestyle medicine and change their attitude to lifestyle medicine. I support them, I support their family around the idea of nutritious food and exercising together. And I start talking about the possibility of remission from diabetes and deprescribing at that point when they first diagnose very early on the condition. This is very different to what people do in deprescribing in old people and end-of-life care. You're talking about deprescribing at the end of a disease process or the end of life, whereas lifestyle medicine is about talking about deprescribing at the beginning of the disease process to motivate and encourage patients to take up lifestyle medicine approaches. The other steps are very similar, okay? I should make a comment on the identified medicines that are appropriate to cease. Medicines that are no longer appropriate could include medicines for diabetes, so hyperglycemia, medicine for cholesterol, medicines for blood pressure, because with lifestyle medicine it changes your weight, your cardiovascular system, and other parameters that these medication may no longer is needed. And if you know, most of these medications are symptom medication or preventative, what I call symptom medication and preventative medication, not disease medication. The next square, prioritizing medicine that should be ceased. In terms of diabetes, medication that is known to cause hypoglycemia, that will be prioritized to cease first. So if they're on a range of diabetic medication, those that cause hypoglycemia would be targeted first, and any other medication that can cause adverse effects as well. The other group of medication that should also be prioritized are those that we know has a smaller reduction in HbA1c. So those are the lowest value medication in diabetes. So we can do that first too. And the reason is that we need to prove to the patient that they won't get withdrawal, okay? It just doesn't bounce back. So you start with low value medication first. You're getting confidence both in yourself, but also for the patient. So very, very important to be mindful of that. So that's deprescribing in the context of lifestyle medicine that I found is useful addition to this process of deprescribing that's been promoted more widely. So these are some medication that I have deprescribed for different patients and successfully as well. So consider these ones, antihypertensive. So as people improve their lifestyle factors, their cardiovascular risk does decrease. Their experience of orthostatic hypotension increase, and so on. So that will be a trigger to think about deprescribing. Antihypoglycemic, as I said, HbA1c is below 6.5. You've got to really start thinking about deprescribing, especially if there has been weight reduction as well, or they have experienced hypoglycemia. Statin, again, low cardiovascular risk, you should consider deprescribing. Vitamin D and calcium, if their mobility improved because you instituted exercise physiology and so on, you should reconsider the risk and deprescribe. Protein pump inhibitors, that's an easy one because it's not supposed to be used forever. But if their symptoms are well controlled with the way they eat and the weight loss, or becomes infrequent, certainly can stop that. Benzodiazepine is definitely something I do all the time because it's not meant to be used for long periods. And also antidepressants, SSRIs, NRI. After 6 months, we always talk about deprescribing. Actually, in fact, I always talk about deprescribing when I first prescribe it as well. That after 6 to 9 months, we are going to talk about deprescribing. I put it in their brains very early on. Okay, so that's the list of medication that you can consider. And I'm only mentioning these.
Apologies for interrupting. A message from the Medical Association. For those that will be applying for CPD points, please enter your email address on the chat box. Please do not forget to do that. Your email address for those that are expecting to apply for CPD points. Thank you. Sorry to interrupt you.
Yeah, I'm almost done. Thank you for that, Isaac. So those are the lists you should be considering. I'm not sure. We've got until 3 o'clock Melbourne time, Isaac.
Sorry?
Do we have another 10 minutes?
Yeah, we could do that. Yeah.
Okay. I was just going to show you a video just to explain how one goes about it. Okay, it's a short, maybe 8-minute video, if that's okay. So let's just play.
Hello, my name is Barb Farrell. I'm a pharmacist in the Brayer Continuing Care Geriatric Day Hospital.
Can you hear that?
Yeah, we can hear that. Thank you.
One of the leads of the Deprescribing Guidelines program of research at the Brayer Research Institute in Ottawa. Our research team has developed several evidence-based guidelines for deprescribing. Deprescribing refers to the planned and supervised process of dose reduction or stopping of medication that may be causing harm or no longer be providing benefit. Each guideline includes a 2-page algorithm to help make decisions about when to reduce or stop a medication and how to do so safely while managing other symptoms that may arise. This video shows how to use the anti-hyperglycemic deprescribing algorithm. Anti-hyperglycemics lower blood sugar levels and are used to treat people with type 2 diabetes. Our first case is Dorothy, a 70-year-old woman who is relatively healthy and living at home with her husband. Starting at the top of the algorithm, we ask ourselves if she is at risk for hypoglycemia, having any side effects from her anti-hyperglycemics, or if there's an uncertain clinical benefit. From her records, we learn that Dorothy's blood sugar ranges from 6 to 10 millimoles per liter. Her recent A1C was 6.9%, and she's taking metformin 1 gram twice daily and glyburide 10 milligrams twice daily, in addition to other medications. At her age and state of health, she stands to benefit from diabetes treatment in order to reduce the risk of microvascular and cardiovascular disease. She says she's had an occasional low blood sugar in the 3 to 4 millimoles per liter range, but says it's nothing to worry about. On questioning, she doesn't appear to have specific side effects with her diabetes medications, though she finds she does need to take the metformin with food to prevent stomach upset. Her creatinine clearance is 70 mils per minute, indicating good kidney function. Dorothy meets the criteria to use the algorithm. She's over 65, she's had occasional hypoglycemia, and she's at future risk because she's taking glyburide. The first step is to set individualized targets. At a healthy 70 years old, an A1C less than 7% is appropriate with the same blood sugar targets as one would expect in younger patients. We also address whether Dorothy has anything else contributing to hypoglycemia, reviewing her dietary habits, especially skipping meals and other medications. We check to see if she stopped taking any medications that could have caused high blood sugar in the past, thus making her more susceptible to low blood sugar from her anti-hyperglycemic medication. Then we check to see if any other medications might be interacting with her antihyperglycemics or causing hypoglycemia themselves. Dorothy is not taking and doesn't have a recent history of taking any of the medications that can affect glycemic control. However, she is taking a sulfonylurea, so she continues to be at risk of hypoglycemia. In terms of deprescribing, there are several options. The dose of glyburide could be reduced, but this may affect her overall glucose control, which has been right at target recently. Another approach would be to switch glyburide to an agent with a lower risk of hypoglycemia, like gliclazide or non-sulfonylurea. For Dorothy, we don't need to consider reducing doses based on renal function because her creatinine clearance was good. The notes on the backside of the algorithm stress the importance of a conversation about deprescribing to explain the rationale, in this case, the risks of hypoglycemia, and the process for deprescribing. These recommendations are informed by interviews with patients about facilitators for deprescribing. After reviewing the options with Dorothy, she chooses to switch to gliclazide MR, 120 milligrams once daily, happy with the reduced number of pills. We'll ask Dorothy to monitor blood sugar daily, checking some pre-meal and post-meal sugars for 1 to 2 weeks to ensure the dose is correct. We can also ask her to report any signs of hyperglycemia, such as excessive thirst, urination, or fatigue, as well as signs of hypoglycemia. If hypoglycemia continues, options include lowering the dose or switching to an agent that doesn't cause hypoglycemia. On the backside of the algorithm, we've listed agents associated with higher risk of hypoglycemia. At a follow-up appointment several months later, Dorothy indicates she's had no more hypoglycemia, her blood sugar tests have been consistently less than 10 millimoles per liter, and her A1C continues to be less than 7%. Our next case is Joe, a 93-year-old gentleman who lives in an assisted living retirement home complex. As we did with Dorothy, we ask ourselves if he is at risk for hypoglycemia, having any side effects from his antihyperglycemics, or if there is uncertain clinical benefit. From his records, we learn that Joe's blood sugar ranges from 2.8 to 9.4 millimoles per liter. His recent A1C was 6.3%, and he's taking metformin 1 gram twice daily, glyburide 10 milligrams twice daily, sitagliptin 100 milligrams daily, and NPH insulin 10 units at bedtime, in addition to other medications. He recently had his hydrochlorothiazide and metoprolol stopped due to dizziness, but is still feeling dizzy, weak, confused, and has had a few falls. He's feeling embarrassed about frequent diarrhea and is also bothered by frequent lung infections, which are usually treated with Septra. Finally, his creatinine clearance is 40 mils per minute, indicating a reduction in kidney function. When medications for diabetes were started many years ago, Joe stood to benefit in terms of reduction of future microvascular and cardiovascular illness. However, occasional low blood sugar and considering other symptoms that may be related to his diabetes medications, it's a good time to reevaluate for potential deprescribing. Joe meets the criteria to use the algorithm. He's over 65, has relatively tight glycemic control, has multiple comorbidities, and a greater potential for drug interactions. He's also had occasional hypoglycemia, possibly with dizziness and falls, has impaired kidney function, and he's at future risk of hypoglycemic episodes because he's taking glyburide and NPH insulin. He also may be having diarrhea associated with his metformin, and there's some uncertainty about the clinical benefit of treatment given his age and comorbidities. The first step is to determine individualized targets for Joe. Given his advancing age, frailty, and comorbidities, an A1C target of less than 8.5% and aiming for blood glucose generally less than 12 millimoles per liter is likely appropriate. This gives us some room to think about reducing some of the antihyperglycemic burden. We also need to look at potential contributors to hypoglycemia. And in Joe's case, the periodic use of Septra is problematic because it can increase levels of glyburide, thereby increasing the risk of hypoglycemia. He's also had 2 drugs that can cause hyperglycemia stopped recently, This could make him even more susceptible to hypoglycemia at this time. For the deprescribing plan, we need to consider reducing or stopping medications contributing to hypoglycemia. In this case, we could stop his glyburide. This would eliminate the drug interaction risk with his periodic Septra. We could also look at reducing or stopping his NPH insulin to further reduce hypoglycemia risk. Switching to other agents like glyburide to glycoside or NPH to Lantus could also be options if glucose rises above the target. We also need to consider reducing doses or stopping renally eliminated drugs, especially if they may be contributing to side effects. In this case, since the metformin may be contributing to diarrhea, we could look at lowering the dose. Now it's time to review the various options with Joe and his family. Joe's pleased about the idea of taking less medication, but a bit nervous because he's had diabetes for so many years. It's important to clearly explain the risks of low blood sugar and other possible side effects as the reasons for deprescribing. In particular, his family would benefit from understanding that Joe's reduced cognition may make it hard for him to respond to hypoglycemia symptoms, and that the potential harm of hypoglycemia can outweigh any continued benefit of tight control of his diabetes at this time. In terms of how changes can be made, there's no evidence for one best tapering approach. Simply stopping the glyburide is fine, but some patients may feel more comfortable reducing doses gradually. Joe's family decides to stop the glyburide immediately and then reduce the metformin next week to 500 milligrams twice daily. Retirement home staff agree to help Joe check his blood sugar a little more often over the next few weeks as changes are made. A logbook with the new targets, as well as signs and symptoms of high blood sugar, is provided. Over the next 2 weeks, the glyburide is stopped and the metformin reduced. The staff report no issues with increased blood sugar beyond the target, and no new issues with thirst, urination, or fatigue. Best of all, from Joe's point of view, the diarrhea improved significantly, and he was able to stop using loperamide. At a follow-up appointment several months later, Joe's A1C is 7.9%. Most of his blood sugars have been less than 12 millimoles per liter, none above 13, and no further episodes of hypoglycemia. At this time, the family asks if Joe still needs the NPH insulin since he doesn't like having the injection. The NPH is stopped, and further monitoring shows blood sugar remaining at target.
Okay, I might stop there. Basically, I just want you to experience how to use the algorithm. It makes perfect sense, and it also reinforces some of the messages I was telling you. So in terms of deprescribing in lifestyle medicine, the key thing is to start talking about it early in the disease process. Describe deprescribing as a positive approach to treatment, okay? It's important to check with the patient's values, preferences, and goals, and to support them with their family and their carers. It's very important to communicate with all team members, especially if they're quite involved in their care, such as pharmacists and other allied health professionals. Have a written withdrawal plan, monitor very closely. If deprescribing is not possible, consider alternative medicine regime and dosing to reduce harm and improve benefit, whilst continuing lifestyle medicine intervention. And that's it. Thank you.
Thank you very much. Now I will invite perhaps to spend a few minutes to address any queries or clarifications that one might want to raise to Dr. Hang. Members, you unmute yourself and ask if you wanted to ask anything before we close off.
Dr. Isaac, mine is a comment. This is Dr. Nefa Dongaro. Thanks, Dr. Ang. This is really good. I think the prescribing is what we often do as doctors. And this presentation actually reminds us that we need to keep doing it, but now do it in a very focused way. My comment is that under the planned Kenya Society of Lifestyle Medicine, we should consider having the prescribing guidelines for our setup in Kenya. This has been really very informative. Thank you.
Thank you.